be able to navigate and have a little chat with our event speakers and sponsors after the conference. So next up, we've got Dr. Debashish Das, who's cardiology consultant and digital transformation lead at Bart's Heart Centre, and also the CEO at Ortus-iHealth. We're going to be talking about cardiology outpatient clinics for the future today. Can you hear me, Dr. Debashish? So sorry if that's pronounced wrong.
Can everyone hear me now?
Yes, absolutely perfect. We've got slides as well, so that's great.
Yeah, it keeps moving away. Hopefully that'll be it, and I'll take away my face for people.
Oh, lost the slides again.
Typical. Right.
Thank you very much. I will see you in 20 for some questions.
Great. So, first of all, thanks for having me. My name's Dr. Das. I'm a consultant cardiologist at the Bart's Heart Centre. I'm also the digital transformation lead for the Heart Centre. But in today's capacity, I'm speaking as the CEO of a digital health company called Outpatients, and we'll be talking about the cardiology outpatient services for the future. But a lot of what I'm talking about will transcend the other departments. But first of all, what a challenging year and a half it has been. This is a picture of the first COVID shift that I did, my first donning and doffing, not really understanding what was going to happen over the next 18 months. And I'm sure I can say this for a lot of my colleagues and those sitting in this conference, is that I'm thoroughly exhausted. I've had 10 days of annual leave in the last 18 months. And just as when we are seeing kind of the light at the end of the tunnel, we're now seeing the effects of what's happened over the last 18 months, the immense backlog of patients. Not only that, we've got more patients, but patients who hadn't presented in their first place and who are now presenting more unwell, more critically down the line to their disease process. And how are we going to cope with this? And, I know as a clinical lead of my department as well, we often just sit with our heads in our hands, think, how are we going to get through this? What we can't do is ask our staff to continue to run at 150 miles per hour that we've been doing over the last year and a half. We can't brute force get through these patients. We have to find new ways of getting through these patients, find ways of prioritizing those who need to be seen, so the right patient is seen at the right time. So I'll just try and briefly talk about some of the things that we've been doing in Ortus, some of my thought processes of how we can try and prioritize patients and then really find that face in the crowd that's just patiently waiting but deteriorating. How can we also more appropriately and efficiently engage with the low priority patient so that it allows us more time with those who are more complex? And really the concept, as we've heard already, about the patient-initiated follow-up. And moreover, I'm looking at it as that patient who's patiently waiting but deteriorating. Now, how can they self-identify themselves? So if we have a look at outpatients of the future compared to what we have now, and this has been said already in the previous presentations, but the current pathway and journey for a patient is really archaic. And if we're all honest with each other, those within the NHS, we wouldn't accept any of that in any other modern working life or part of business or what we have to deal with. I did an audit just prior to this conference because I wanted to know. I asked all of my patients whether they had received either their appointment letter or my last clinical correspondence, and it was less than 40%. So that cannot be right. We have to find a way of frictionless but friendly, patient-friendly apologies, way of seeing our patients. Our pathways and our consultations have previously very much relied on information gathering during the consultation, which could have been done previously. We deliver clinical information to the patients usually during the last 5 minutes of the consultation. They often don't have a repository of where they could go back and refer back to. We book follow-ups, not due to patient priority or patient need, but my 6 month, if we're honest, my 6 month, 12-month follow-ups that I put regularly, it's usually down to that's when my next follow-up is. So we have to, again, move away from that. We need to move into a way of a more efficient but more personalized consultation, where we gain all of that information that we can prior to the consultation, allow the patient to have a really focused consultation that is designed to their needs, and have a mechanism where we can follow them up more efficiently, but with much less low touch. And with that data-rich environment, actually outpatient appointments will be based on outcome optimized. What that means is not that every patient needs to be seen 12 months down the line or 6 months, but it is based on data. So with that, with increased patient engagement, with self-management and an ability to have two-way communication that is seamless, we will not only improve our efficiency, but we will, and there is evidence to show that we will improve our health outcomes. And we have to get through the structural barriers that they're there. We know that we have legacy IT systems that are often very difficult to move away from due to the change management that is involved. So that doesn't mean we can't move forward. We must ensure to get solutions that can help with this, but that they integrate with your legacy systems, and then have a outpatient that's responsive and flexible for not only the patient, but the clinician. So what was our objective? So I had already started this journey prior to COVID. A year and a half prior to COVID, we had already quite a large virtual clinic program within Barts and the cardiology, as well as an oncology department. We need to lay the seeds of what we were trying to achieve. And what we wanted to achieve was an improved user experience, but not only the patient, but the clinician as well. We wanted to create a single platform that connects the journey of the patient from start to finish, which integrates what I quite often described, quite often are disparate solutions. We've talked about patient portals. There may have been talks about remote monitoring and PROMs. Patients and clinicians will get app fatigue. It is what is consistent amongst that journey is the patient and the clinician. They want one automated, seamless pathway. So what we've created is a solution that allows to have essentially a patient portal where they can get their appointments. You can gather information before a consultation, or even deliver information before consultations, like a digital consent. Remotely monitor them pre or post aftercare, and then on a population level, analyze the data to allow you to optimize your pathway. A key focus of our design was to try and automate it as much as possible. Cardiologists like me are not known for their attention span. In fact, my 10-year-old daughter often calls me Dory from Finding Dory. I took that to the principle of how we're going to design this. Our key design methodology is that nothing should take no more than three clicks to do. Because if you don't engage with the clinicians, And if you don't make it as frictionless for a clinician, the patient, unfortunately, still in this day, will not see the benefits of the modern digital healthcare. So what we try and do is automate as much of the pathway as possible. A clinician can easily design the appointment structure, the questionnaires based in time, the consent, what information they want to gather or deliver. And with 2 clicks, once you've designed it, any patient can be assigned that pathway. It then allows a single pointer dashboard where clinicians can review all of that data. And you can analyze patients on an individual basis and prioritize the patient that is deteriorating, or you can analyze if your pathway is working on a population level and take action. And what does that mean for this unified experience? Essentially, it is a portal for a patient where they can get their appointments, they can get their health-related information, be it videos, PDFs. They can get their clinical letters. They can input their symptoms, connect it to your Fitbit or Apple Health device or your Bluetooth blood pressure monitor. So it's a single area where a patient can put all of that data. Patients can either use the website, which behaves, if you put it through your mobile phone, as an application, or they can download the app itself. For clinicians, you have a very easy to navigate portal where they can see all of that data that patients are putting in, but they too can communicate with their patient seamlessly, and then the patient will get that information. We split it into these, what we call our 5 circles or our 5 pillars. The access for the patient, the easy ability for assessment and delivery of information, the remote consultation. A lot of the access and the assessment can facilitate even enriched face-to-face consultations. But if you wanted, you've got the video consultation through the portal to easily video patients. Then the remote monitoring capability. With all that information and data, we produce dashboards for clinicians to monitor patients' progress, both on an individual level or a population level. So I'll give you an example of a couple of pathways that we have already that's live. Patients who want to or are being put on a procedure pathway are with 2 clicks given their pre-assessment appointment virtually with their pre-assessment form that they fill in. They have their digital consent that is put on there. They are placed on their virtual ward remote monitoring, where we can identify a deteriorating patient if need be. They're then seen. They've had their procedure. The system automates sending them the PROMs at the time frame that you have designed, be it 3 months, 6 months. No one has to go in and remember to send them. And then we analyze that data and improve our pathways. Other pathways for more acute patients are, for example, our post-heart failure admission and our virtual ward. So there are multiple different tool sets within the system that is always integrated. They're not separate. We don't have a separate virtual ward or a separate patient portal. It is all integrated, still using that 3-click principle. So our pathways are structured, as I mentioned, and automated. And that can be from referral to consultation, from consultation to treatment or procedure to discharge, or from start to finish. And for our clinicians, we have that dynamic dashboard for patient assessment and prioritization, the ability to identify a patient who may be deteriorating or communicate with them easily in an outpatient setting. So what that does is take that generic list that we have in an outpatient setting, for example, but it allows you to put them in scales of priority from low to urgent. The urgent patient who's put in a questionnaire or a symptom that they're deteriorating, can quickly be sent a message or quickly be video called. It acts like a WhatsApp video. You can almost just click the camera and it will start ringing the patient. Or you can bring them in as a face-to-face. The low-risk patients, and this is where I believe is the real going to be the efficiency drive for our NHS, is the asynchronous reviews. So my clinic at present is a blend of the three. There'll be the face-to-face that are brought in because they've inputted in data that I feel I need to see them. I have my video consultations that are personalized and enriched and shorter because I've gathered all the information prior to seeing them. Then I have a asynchronous group of patients. Those patients I've given a medication to, I just want to know, has it made them better? Or I've given them a blood pressure tablet. I just want to know whether it's if I can increase their tablets due to their blood pressure and heart rate. And all I do, the patients put that information in, and I send them a message through the portal. To put that in context, be it a face-to-face consultation or a teleconsultation where I have to speak to a patient, takes between 15 to 30 minutes. An asynchronous review takes 5 minutes. So within an hour, I can see at least 10 patients or deal with 10 patients in an asynchronous manner. Now, consultants and clinicians have been doing this for some time already. They've been dealing with email queries or stuff. We have just never structured it in that way. And we've never restructured our clinics to facilitate those asynchronous reviews. So what are the results? Now, we have a number of different pathways within St. Bart's. Some of the pathways that have shown a nearly 58% increase in their capacity. And that really is about from the asynchronous component. All of our heart attack patients are given Ortus at Bart's Hospital. And during our COVID pandemic, through the virtual ward, it allowed the confidence to discharge them earlier. And we're up for a BNJ award. We'll find out in a couple of days whether we want it. Our patients were discharged normally from 3 to 5 days, from 1 to 2 days with our remote monitoring virtual ward capability. We've introduced the concept of asynchronous reviews using allied healthcare professionals. Our pharmacists now up-titrate medications remotely based on blood pressure and heart rate readings for the heart failure and heart attack patients. And compared to our previous audit, where we were getting only 11% optimization of our patients, we've now increased that to 85% with very little resource. We know that remote consultations reduce the DNA rates, simply because we are now knocking on the patient's door. A lot of our clinicians, I'm sure, have had similar for me. We've called or videoed patients and they've actually forgotten that they had the appointment, but because we are calling them, they continue to do their appointment. Through this efficiency saving, we've been able to also reduce our time to our follow-up. At Bart's, we've put over 5,000 patients through the Ortus portal, through varying pathways, from cardiology through to oncology, diabetes. We've had high patient satisfaction, a high completion rate of the questionnaires that are put in. And we know through remote consultations that patients save time and money. It's not for all, but we know that there is not every patient requires a face-to-face. What we do now need to move into is not every consultation requires a synchronous conversation. So my last kind of suggestions or thoughts that I'm going to try and take into my practice is to go structured, go integrated, and go automated. Try and make that the foundation of my patient engagement. Go through data and dashboards. Try and see the right patient at the right time through the tools that allow me to identify a patient risk. and allow my patients to initiate follow-up where they require. And most importantly, change my clinic template to allow for more asynchronous consultations. Our patients are becoming more and more transactional. They're more used to these digital transactions, as previously said. I know when I go on a website now, the thought of calling a phone number that no one's asked, I'd rather deal with a chatbot that would quickly answer my question. It's not for everyone, but we're not building healthcare that has to be homogenous. There is a place for this that will allow us to release real efficiencies, but also improve patient safety, clinical outcomes. Any questions?
Dr. Das, can you hear me okay?
Yep.
Absolutely brilliant. We've got a fair few questions to go through, so we shall crack on. Anne Bream has asked quite a simple one, but can it connect with Cerner?
Yes, so we have connected already to the Cerner sandbox. We're planning on connecting to Cerner, but as you can imagine, the last year and a bit has there's been a lot of priorities from our IT team to go through. But yes, so we are HL7 Fire compatible. We've already connected to the Cerner sandbox, and we can. It will be a relatively quick process for us to connect to other Cerner sites.
Brilliant, thank you very much. Laura has asked, what percentage of patients access the portal, assuming not all patients are able to or motivated to access? How do you interact with these patients?
Yeah, so I think what's important is we've done a lot to try to make this as user friendly for our patients as possible. For that reason, it's a web portal as well as a app. We find that our more elderly patients are far more find it easier just to go to a website and work through it. You see our portal; it's just big tabs, nothing overly complicated. I mentioned our oldest patient is 94 years of age. We've also found actually elderly patients are far more digitally enabled than we give them credit for. And where they aren't, it allows for patient and family activation. Family members can help them with their healthcare. You can allow family member access for them to help or join in on consultations, or for them to answer questionnaires on their behalf. So done in the right way, you can have patient activation to reduce the digital exclusion. However, there will always be a group of patients that are digitally excluded. But we cannot base the healthcare of the future. We cannot not progress for them. We have to make mitigations for them, such that 80% of the population benefits still.
Yeah. Like you say, I think it's probably in the minority now that aren't tech savvy, isn't it? So it's making sure.
And COVID has exacerbated that. Even my father now knows what a QR code is. 3 years ago, I introduced a QR code for the ability to download the app, and even the 40, 50-year-olds didn't know what was going on there. So there's been a lot of digitization that has been enforced on us through COVID.
Definitely. Very much for that. That's great. So Jonathan has asked, so he said, it sounds great. To what extent do you think it stopped the patients presenting to their GP asking for their appointment to be expedited? Any thoughts on how to manage this demand, which is increasing due to long waiting lists? Great question, Jonathan.
Yeah, absolutely. We know, and we have evidence within ourselves, that we know that easier access to your secondary care physician stops them landing on your general practice doorstep. I say that as a father who's a general practitioner and a brother who's a clinical director from a primary care trust. Their bugbear is, why can you not just speak to your secondary care consultant? So we have to have, our general practice is far more advanced than secondary care, to be quite frank. We know that allowing for easier access to be and being able to just deal with queries stops them not only landing in general practice, but stops them landing in A&E. Now, to the second part of that question, in secondary care, we have to stop treating everyone as the same or in time order, because actually the disease doesn't behave in time order. Yeah, patients can fall off the cliff just because they're 1 week into their pathway. And we have got such a backlog that we have to have mechanisms for identifying that. And that is either through vital observations or self-reported outcomes or questionnaires. So through the system, on our elective care pathway, it automates and sends patients questionnaires, deteriorating questionnaires, on a predefined time frame. If a patient answers a questionnaire in a certain way, which suggests they're deteriorating, it highlights on a dashboard for a clinician to review. And yes, you have to have mechanisms in place that someone is reviewing that dashboard on a regular basis. But it allows you to quickly identify someone and then either bring them up the pathway, quickly review them to stabilize them, or actually, no, they're doing okay.
Perfect. I think, I mean, how would you this is just off my back here, how would you kind of navigate the people that would inevitably obviously highlight maybe not highlight, but increase their urgency, but not actually need it?
Yeah, look, I in my experience, there will always be one or two patients who will game the system. In my experience, actually, the British public are far more honest than we give them credit for. The more common thing is that them just deteriorating on a waiting list, not trying to bother anyone.
Yeah.
That is so I'm much more comfortable having a system that, yes, will have one or two that may use up more resource or game it, but it protects the vast majority. And we've seen that everywhere. Most patients, they don't bother the system unless they need to. We've all got busy lives, we've all got things to do. If they're contacting us, it's because they need us.
Yeah. In silence is the quote, isn't it? And it's heavily seen, isn't it? Just before we end, Dean has asked here, how do you ensure the privacy of patients on the other side?
So all of this, the system has privacy-related assurances. We have a privacy impact assessment. Anyone that goes on the system knows that we are accessing the data. With regards to privacy, we are DSP tool compliant. We are ISO certified. This may not make a lot of sense to the patient, but there's a lot of credentials that we have to go through that ensure that we are data protected, protecting the patient, and privacy compliant. So there's lots of we're on the Spark and NHSX framework, and to get on that, you have to have lots of rigorous processes to be able to, with regards to data. And it's an evolving picture, and the data security is we're constantly iterating our security and privacy.
Perfect. Dr. Das, it's been an absolute pleasure. It's your first event with us, and hopefully it won't be the last. Brilliant presentation, great engagement, and just a big thank you from us all here.
Thank you so much.
Thank you. Take care. See you again soon.
Bye.
Cheers now.